So I put the links for the references and the slides, which I put on SlideShare. So we thought we'd just introduce ourselves in a few words to start with. I'm in the information school at the University of Sheffield in the UK, and working from home at the moment, also using my husband's computer because he's self-employed, and so he has the good internet connection and the best kind of setup. And I thought I'd also mention about 20 years ago, I was chair of the European chapter of ASIS&T. So a long time ago, I was quite involved. And so Pam,
yeah, hi, I'm Pam McKinney. I'm a lecturer at the University of Sheffield Information School, and I've worked quite a lot with Sheila. We work a lot together, so we're really excited about the presentation today.
Okay, so I'll share my screen now. And hopefully you can now see it. And I'll go into presentation mode. Okay, so we're talking about the information worlds of non-resident informal carers and stakeholder perceptions. And this first picture is taken by me in the 3D virtual world Second Life, where I'm very active. And it symbolizes the fact that if you're a non-resident carer, you seem to spend an awful lot of time traveling between one place and another, and also that it can seem quite a lonely road. So the structure of the talk is going to be that I'm going to identify the aim and the rationale and the study methodology. Then I'll be handing over to Pam, who will talk about the theoretical framework and the part of the findings, and then she'll hand back to me again for the final part of the findings and to give very briefly our next steps. So the aim in this presentation is to illuminate the distinctive elements of the information world, and Pam's going to explain that particular framework in due course, of non-resident informal carers of elderly people. And this was achieved in this initial study by gaining insights from stakeholders and organizations working with the carers. And I would say that this small study was funded by 2 small grants from the Information School, and our aim is to do a larger study actually investigating the worlds of the carers directly. So we thought we should define informal carer, which refers to all non-professional care provided by choice or by default by family members, next of kin, friends, neighbours, or other persons caring for people with long-term care needs. And usually in private households. And then non-resident informal carers are people who don't live with the cared for person. So the rationale is that it's difficult for elderly and their carers to cope with all the information they need in order to make all the right decisions for the cared for person and also for the carer themselves. And there's a lot of evidence that family members, friends, people close to the cared for person are very important in terms of making sense and managing the information, including health information. And also evidence has come up, including in very recent studies, that despite the fact that governments tend to be driving more and more information online, people want personalized advice rather than going to some generalized place. They want individualized and a feeling of a person behind the advice that they're being given. And including recent studies, we find that there's differences in the way that different age groups use information. And this isn't hard and fast, and you have to look very carefully because there are huge variations. For example, I am an older person. I qualify by any category, but I use the internet a lot. I'm very familiar with online. There would be people my age who are much less familiar. But there are, in a general terms, differences which are emerging in the use of COVID information. Now, when we examined the literature, we found that there's a big focus on resident carers, people who actually live with the cared for person, with their child, with their spouse, and so forth. But this topic really arose for me from my own experience of having to care at a distance for my mother in the last year of her life. She lived in Sussex, which is several hundred miles away from Sheffield. And this was a stressful, difficult time trying to manage my different responsibilities of work, other personal relationships, and those of my mother. And then talking to other people, realizing they had similar problems, because certainly I was overwhelmed by the information. I find it, although I think I'm information literate, I found it was a real struggle to try and cope and understand the messages that were being given, what to pay attention to, and so forth. The methodology for this small scale study was that we had semi-structured individual, mostly individuals, a few group interviews with 11 individuals in 7 different formal care providers in Sheffield. Some of them were charities. It also included the city council and the social care managers there. And we approached the stakeholders initially, partly to get a broader perspective, because they would be aware of some of the macro kind of national issues and the local issues, some of the structural economic issues that arise and which the individual carers might not be so aware of. And also we needed evidence for our larger study that there was actually a problem there, that there was a problem specifically to do with non-resident carers. So the interviews which were quite lengthy and deep, were transcribed and analysed by me and Pam and Mary Crowder, who was the person who collected the data and also assisted with data analysis. And we used Burnett and Yeager's information world theory, which also incorporates Chapman's idea of small worlds. So I'm going to hand over to Pam to do the next part.
Hi, yeah, thanks, Sheila. So the concept of an information world was developed to refer to the information environment and social norms of a particular group, and that's been further developed by Burnett and Yeager into their information worlds theory, which encompasses information at multiple levels of society. So it was designed to provide a framework through which the multiple interactions between information behaviour, and the many different social contexts within which it exists, which we've represented diagrammatically here on this slide. So information worlds theory builds on Habermas and his information life world, and on Chapman's theory of life in the round. So one way that information worlds theory extends these two theories is that Chapman doesn't account for the interactions between small worlds and the broader society, or the interactions across and between multiple small worlds. So we can see here in the diagram that information behaviour is subject to influence at 3 levels of society: the macro, intermediate and micro, represented on the left of the diagram here in green. And this is in recognition that information behaviour as larger social influences such as media and politics. There are 3 levels of interaction, so access to information: physical, intellectual and social, represented in blue in the middle of the diagram. And finally, there's a focus on the 5 social elements that shape the social structures within information worlds, represented in yellow on the right. So as information moves through boundaries between small worlds, the information is treated and understood and used differently, which we thought was particularly relevant to this study. So this theory informed the analysis of the data, and it's used to frame this presentation, thinking particularly about the 3 levels: the macro, intermediate and micro levels of access. Sheila, if you'd like to move it on one slide. Thank you. Yes, so we're going to focus first on the macro environment, which is the provision of social care in the UK, policy, outcomes and measures of effectiveness for information provision, which we've looked at as part of this study. So the policy background really in the UK is that medical care is handled on a national level through the National Health Service, but there are variations between the home nations of England, Scotland, Wales and Northern Ireland in terms of how it is actually managed. Whereas social care, which is the care of people in their own homes, of elderly people that isn't deemed to be medical care, is devolved to local authorities and councils and isn't in fact integrated with NHS provision. As you can imagine, this lack of integration between social care and the NHS causes a lot of problems in the UK. So the NHS is a nationalised public sector organisation, but increasingly the UK government is trying to sort of attempt a free market ethos to generate a competitive market. So, for example, in care home provision and increasingly privatised medical services, and that's affecting the provision of care as well in the UK. So the Care Act was published in 2014 and it requires local authorities to provide comprehensive but neutral information about care and support services. So they have to provide information about some of these privatised services as well as any services that are offered by charities. And theoretically, there should be a good level of information provided about these services, but 51% of carers who were surveyed said they had difficulty finding the information that they need. Now, the provision of information for carers is monitored by the Adult Social Care Outcome Framework, alongside lots of other aspects of the social care provision in the UK. And we found out in the course of our research that Sheffield doesn't do particularly well in these measures. It's ranked 144th nationally for how easy carers report being able to find information. Some of the demographic information that informs the macro context as well is that, in common with many other countries in the world, we have an ageing population. There are 9.2 million people who are aged 65 plus. And this is positioned very much as a problem in the UK, that these elderly people need support, that they're kind of a drain on society. So alongside these elderly people, there are 4.5 million informal carers in the UK. And a lot of these, 76% of the carers, provide less than 20 hours of care each week and don't live with the person that they care for. So you can see there are a lot of people who are affected by this. So I'm going to move on now to talk about the intermediate environment, which includes the provision of social care and information about social care in the Sheffield City Local Authority, and thinking about services. So one of the side effects of this privatisation of social care is that the social care system is very fragmented, and there are lots of private and public care agencies and charities, which means they all have their individual processes and procedures. And our participants identified that this is really challenging to come to terms with. And there's a big tension between the desire for family carers to seek recommendations for services. So they want to know what's the best care home, what's the best place for my elderly relative to go. And this is set against the Care Act's principles to provide neutral information. We discovered that there's a lot of signposting activity going on. So an individual agency, if they feel they can't help that particular person with their particular problem, they'll refer them on to a different service. And it's quite difficult for carers to deal with that kind of referral because they feel like they're just being passed on to somebody who doesn't really understand them. So I'm going to hand back to Sheila, I think. Oh yeah, so there are 20,000 carers in Sheffield who begin and end a carer journey each year, and it was identified by the local authority how challenging it can be to provide information for all of those people. And it was identified that better provision of information was a key factor in terms of supporting carers and providing a more effective support service. There's also a problem in that different local authorities offer different services and apply different criteria to access support. So when you get a situation where a non-resident informal carer lives in a different local authority to the person that they're caring for, it can be very difficult for them to access support, partly because they lack knowledge about what might be offered in that particular locality, and also because they just haven't got the right kind of information. Yeah, Sheila.
So I'm just going to present the last few slides about the microenvironment and the next steps. So this is looking at the kind of individual level, the feelings of the people providing the services and the carers. And one finding is that there's less access for the carers to the small worlds of the care providers and the small world of the cared for person. So the carer needs to learn the insider norms of the small worlds of the different agencies, the jargon, their values, the way they work. But they have less contact with the health professionals and formal carers of the cared for person than someone who is there all the time. They won't be there every time the carers visit, the health people visit. They won't be there every time the cared for person might go to the doctor or be visited by the doctor. And therefore there's less opportunity to seek, receive and share relevant information and gradually to get to know these small worlds and work out how to engage with them, how to motivate them, and how to create a relationship with them. Also, in terms of the cared for person, because they're likely to be someone that obviously they know well, like a parent, but nevertheless, it may be that they have their own norms and values and their own social worlds. And the non-resident carer has more limited access to the information about the day-to-day care needs, the day-to-day life and welfare of the care for person. So it may be easier for them to miss out on some health information because it might be easier for the cared for person to cover up some particular problem that they don't want to worry their carer about. There's also less access to formal and informal networks, so they have less knowledge of the local support services and infrastructure in terms of the medical and care infrastructure, and some of the advice services and information services we discovered are only available to people in that region. So it may be that there are really excellent carer support groups, but you can't belong to it because you are in some other region of the UK. And also there's an informal networks. They may be able to tap into these via the cared for person, but if the cared for person is getting more confused, perhaps has got out of touch a little with these informal networks, that's going to be a problem. And all of these problems have been exacerbated by COVID-19 and the lockdown, making it, I think, more of a nightmare for people. I'm talking anecdotally to people I know, making it more of a nightmare to actually deal with these issues at a distance and making really hard decisions about, do you actually go into lockdown with this person that you don't normally live with? Do you stay at a distance and therefore find it anxiety provoking and more difficult? So those are some of the findings from this initial scoping study with the stakeholders. What we want to do, which we've been working towards, is to carry out case studies focusing around a cared for person and the non-resident carers that care for them, and to explore those in great depth using different forms of data collection, observation, diarying if the carer is interested in that. And then mapping out the various information worlds that they encounter. And we'd be very interested in connecting with any other researchers, for example, in other countries or other regions of the UK, who would be interested in joining with us in working on our bid. We've got quite a worked up bid that we've been working on this area for quite some time. And so we are very actively interested in finding other people who would like to work with us, or people who've already done similar work with non-resident carers. So I'll stop sharing my screen now.